All right, this is going to be airway management and ventilation. This is going to be part 4. And topics in this are going to be difficult airway. Um, a difficult airway is a situation in which a conventionally trained paramedic experiences difficulty either with BVM ventilations, endotracheal intubations, or both. 1 of 10 airways can be classified as difficult. Endotracheal intubation may be impossible in 1 of every 100 patients using conventional methods, and this is under direct laryngoscopy. A difficult airway is constituted by airway, problems with mask ventilation, problems with laryngoscopy, or problems with intubation. So this is a kind of a problem shooting or troubleshooting guide that's used for slam airway and difficult airway. So is it a difficult airway if it was unrecognized? Let's see if we can mask ventilate the patient. I'm going to talk down a couple, 2 or 3 of these things here. And was that successful? If yes, then able to ventilate non-emergency pathway, intubation techniques, and then we can try several things, various stylets, a retrograde, an Eichmann or a bougie, and then maybe some kind of fiber optic device. And then hopefully it's successful and we've confirmed the airway. Again, difficult airway. This time the patient was paralyzed and it was unrecognized. Intubation techniques, they fail. Can we mask ventilate them? Let's say in this case that fails as well. No, unable to ventilate, run immediately to or go immediately to the emergency pathway. Try a secondary alternate airway, which would be an LMA combi tube, transtracheal jet ventilation. If that fails as well, initiate a surgical airway. Let's look down this side too. Recognized airway problem, time for proper preparation. If the answer is no, try to mask ventilate them. If that fails, then we're looking at the same pathway here. If we do have time to prepare and we have awake intubation choices and can adjust our intubation technique via variation of devices, we can confirm it pretty easily. This would be the pathway we would want to go. If those fail, surgical airway, then confirmation of an airway. Difficult mask ventilation. Inability of unassisted paramedic to maintain a pulse ox greater than 90% using 100% oxygen and a BVM on a patient whose SpO2 was greater than 90% before ventilation. Inability of unassisted paramedic to reverse or prevent signs of inadequate ventilation during BVM ventilations. Most of the time this can be combated by a 2-person technique. However, the larger someone is, the more difficult it becomes to actually ventilate them by lifting the weight of their chest during ventilation. Difficult laryngoscopy. Inability to visualize the chords during conventional laryngoscopy. And we're going to use this in Mellon-Potty scales here in just a few minutes. A difficult intubation. Conventional laryngoscopy requires greater than 3 attempts or greater than 10 minutes. Historical factors of a difficult airway. History of difficult airway management. History of difficulty with anesthesia. Obtain history if the situation allows. So if the patient has any type, have you ever had a problem being intubated? Yes, they had a heck of a time. Have you ever had any problems with anesthesia? Well, yes, I did. Obtain history if the situation allows. So some of the times you get thrown into the fire and won't have enough time to obtain a history. But if you can obtain one, especially in the critical care environment, you should. Prior proper planning would prevent piss poor performance in this. Anatomical factors. Upper airway anatomy differs greatly among individuals. Several factors associated with a difficult airway, and there's not one reliable indicator by itself, but there are some specific factors that are noted, and the more of these that we actually get, the more difficult the airway seems to be. One of those being a short neck. If a person has a thick neck, if their neck looks like a tree trunk. Restricted range of motion, whether that be extension or flexion. Dentation, their actual teeth, if they have an overbite, this is going to decrease our ability to move the jaw up enough without doing maybe damage. Macular occlusion, or teeth that are misaligned. A small mouth, less than 3 centimeters, is problematic. A short mandible, also on that list. An anterior larynx. Thyromental distance, less than 3 centimeters, is problematic. To measure the thyromental distance, it's measured from the upper edge of the thyroid cartilage to the chin with the head fully extended. A short thyromental distance equates with an anterior larynx. So this would be a more anterior looking airway. Obesity also is in this list, and anatomical distortion, whether that be from trauma or medical pathology. Example would be tumor, surgery in that area, and whatnot. Airway assessment systems, the Malampati classifications. Assessment based on visual assessment of the oropharyngeal anatomy. Higher the grade, the more difficult the intubation. Little application in emergency medicine. The patient must actually sit. Patient must open mouth wide and protrude their tongue to the best of their ability. Easiest way to get somebody to do this is to say, hey, open up your mouth as wide as you can and stick out your tongue and say, ah. Sometimes this is kind of difficult for people to do when they're in extremis or near death. May not be able to get this scale on every patient. The Malampati classification systems are easier when we see the picture. The next slide will actually look at the picture. So 1, the uvula and tonsils are completely visible. At class 2, upper half of the uvula and tonsils are visible. At class 3, hard and soft palate are the only things that are visible. And a class 4, hard palate only is visible. And this is what we would look at. So if we can see this and the tonsils, that's going to be a class 1. If we can see half of it, a class 2. If we can only see soft and hard palate, class 3. If we can only see hard palate, class 4, Malampati 4. The Cormick-Lehan grading system, and this system is going to grade it on the view of the glottic anatomy, and this is going to be under laryngoscopy. So a grade 1, entire glottic opening and vocal cords are visualized. This means we can see 100% of what we're looking at. Epiglottis, grade 2 is epiglottis is partially obstructed view. Posterior glottic opening and posterior vocal cords are visualized. A grade 3, epiglottis fully obstructed view of larynx, no vocal cords seen, or posterior cartilage visualized. And a grade 4, inability to visualize the epiglottis. And grade 1, 100%. Grade 2, about half of it. You could almost say that this was 75%. Nope. And then this one is 25 maybe, give or take. Pogo. Pogo is very simply, how much of this can I see? Percentage of glottic opening ranges from 0 to 100. 100% would be I can see the entire glottic opening. and this would be a way to grade difficult airway. Pogo scale of 75%. Last but not least, we should talk about the angle. We have 3 different angles that we are looking at whenever we are trying to look or visualize the glottic opening. We have the oral axis, we have the pharyngeal axis, which goes all the way down here, and then we have the laryngeal axis. Now, the thing is we tend to want to bend the head back greatly. Even had people grab a hold of the arms and move the arms in this direction. If we could just get the head back a little more, we could see the glottic opening. Sometimes that's not the problem. The problem is we should adjust the environment so that we get the best look. The sniffing position is probably the shortest distance to looking at the glottic opening. And what I mean by that is if we can get someone, if they're non-traumatic, and get them into a sniffing position, we have our best chance of seeing the glottic opening. Sometimes the easiest way to facilitate this is to move the head up instead of down and back. So again, something to consider. The consideration is sometimes maybe put something underneath the head so that it changes the aspect and the angle that you're looking at. This ends part 4, talking about the difficult airway. If you have any questions, feel free to email them to me, roy.smith@redlandscc.edu or smithr@imsa.net. Thank you.